fine?
You can see Dr. Pranashit as well.
Yeah, Dr. Pranashit is here.
And
so this meeting is going to be quite interactive. I believe that we'll.
I believe Professor Khushid is here as well. Can I see Professor Khushid?
See. I think we can start talking. Then we can review some of the important issues at the end of the
Dr. Pranashit, you look very bright today. What's the matter? We all become depressed, but you look very bright.
Dr. Pranashit made a very good contribution in the last webinar that held yesterday evening, last evening.
All right.
It was very good. His contribution is well appreciated.
I'm sorry I missed that. I mean, I was a little bit engaged with some family business.
Okay.
So shall I start, sir? We have got.
Yes,
I think.
Yes. This is the time that we should not waste any more time. We can start right now.
Just.
So can you give a little introduction about the kidney cancer? So far we have done almost 3 webinars as a master class, and this is going to be the 4th one.
Hey, Dr. Salam, I think we'll wait for Dr. Kabir, right? I think when he's done, we can get started.
Yes.
Oh, hello, good afternoon.
Good afternoon.
Dr. Pranashit, you are looking really bright.
Yes, sir. Thank you. Thank you for the compliment. And very good morning for our speaker, sir.
Yes.
Thank you very much. Good morning.
Good morning, sir. How are you? Fine.
Very good. Very good so far.
Dr. Chaudhary, assalamu alaikum.
Assalamu alaikum. Hi.
Oh, Dr. Kamal, you are elegant.
Yes, sir.
So, shall I start, sir?
Yes,
shall
please.
I start just the beginning? So welcome you all at this 187th episode of a multidisciplinary GU meeting of Urology and Transplant Foundation of Bangladesh. As you know, Utfb have been conducting this type of meeting in the form of tumor board, lecture, masterclass, interactive discussions over the last 8 years. So in this present reality of pandemic, we are conducting this meeting in the form of webinar. This is our 7th webinar, and in the meantime, as you know, we have lost a lot of our colleagues, doctor colleagues, as well as senior teachers from our own community as well. And we really we lost our beloved teacher, Professor S.M. Kibriya, Dr. Moin Rashid Chaudhary, Dr. Faisal from UK. We solely actually pray for their departed soul. Today's topic is the continuation of RCC masterclass, which was a follow-up today's follow-up masterclass today, and our topics today is, as you know, follow-up of RCC, AUA Guideline, case-based discussions. And the last three discussion was on organ-confined kidney cancer, locally advanced kidney cancer, as well as metastatic kidney cancers. And we have selected our speaker, none other than Professor M.S. Chaudhary, who is intimately related to AUA, as well as our Utfb. And he works in New York Medical College as urology chair. I think he does not require any more introduction today. We also have a panelist, selected panelist, Dr. Mohtar Ahmed, probably has some, I don't know, he's able to join us today because he has some theater to do, I believe. So I don't know whether he can join us today. And we also have Professor Khan, Professor Colonel Mofazul Hossain, and Dr. F.M. Kamal. I also will request particularly Dr. Pranashit Shah, Dr. Khushid to join us as a panelist, because if this is a very hot topics and we need more participations. Today, Professor MS Salam, President of Utfb, will chair these sessions. May I also request other participants all to take active part in the discussion after finishing the professor, because there is only one lecture today, and Professor Choudhury, as we requested, he has prepared probably in the same way, because we request him to prepare a case-based discussion so that we can understand the follow-up situation in different types of tumor, and as you know, there is no consistency of surveillance after RCC treatments, and there is no evidence that early versus late diagnosis of recurrence improves survival. The intensive radiological surveillance for all type of patients may not be necessary. However, follow-up is important to increase the available information of RCC, the time of recurrence or development of metastasis. Surveillance after treatment of RCC to monitor and identify post-operative complications, renal functions, local recurrence in contralateral kidney, as well as development of metastasis. So with this few may I request Professor MS Choudhury to start his lecture. Professor Choudhury, please.
Sure. So what I'm going to do is I'm going to share the screen, right? I think because, okay. Okay, can you see the slide?
Yes, sir, we can see it.
We can see the slide. Okay, very good. Can you hear me well?
Yep, it's clear.
Right, you can hear me, right? Okay, so let me go back a little bit. So Dr. Jahangir Kabir and Dr. Salam wanted to do a case-based discussion. So what I basically did, if you look at this one, this will be more on renal cell cancer. Hopefully it will be based on guidelines and evidence-based management of the cases we will present. These are cases which I have, some of these are my cases, and a lot of the other cases are presented in our weekly Grand Round conference. And if you look at the pictures, there are 3 institutions in our program. On the very left side is the Westchester Medical Center, which is the primary institution. Then we have in the middle Metropolitan Hospital, which is in New York City in Manhattan. And then on the very right side is Lincoln Hospital, which is in Bronx. We also availed Dr. Mutahar Ahmed's hospital, Hackensack University Medical Center, but we do not present cases from there. We only present cases when the attending is in presence at the time of the Grand Round. So most of these cases were discussed in the Grand Round conference. So just like any other tumors, we try to get consensus based on evidence and guidelines for the treatment. But just like any place in the world, it doesn't work all the time. But what I will do, I'll present some cases. We'll start from a very small renal tumor incidentally found and go up the ladder and try to present all of those cases. And hopefully all of the panelists or anybody who wants to participate will contribute to the discussion. So keep in mind, there is not a single way to treat any single patient. So there will be differences in opinion in how we treat patients, but that's perfectly acceptable on this one. Remember, the guidelines are not very strict because even the evidence is not strong in a lot of cases. So with that introduction, I will start. These are the residents who present cases over the past 2 years, and those are the cases I'm going to present. The very last person, right, you could see is Dr. John Phillips. Dr. John Phillips is not a resident. He is chief of section of uro-oncology, robotic, and laparoscopy in our institution. So I'll start with the first case. So this is case number 1. Over here, we do not put the full name of the patient, just the first and last digit of the first and the last name of the patient, so that the patient is not identified completely. So this is a 66-year-old female, and she had an incidentally found mass about 1.6 centimeter in the left upper pole. So keep in mind the size of the mass is only 1.6 centimeter. Incidental, she has absolutely no symptoms. This was done for a totally unrelated reason, the CAT scan, and that's when they found that 1.6 centimeter mass in the left upper pole. She has past history, which is hepatitis B, history of cirrhosis, mild cirrhosis, diabetes mellitus, and hypertension. One of the things we always want to know in this patient is her glomerular filtration rate, GFR, normal, and her GFR is over 60 ml per minute. So she does not have any CKD at this time. So this is the, if I point it out, I think hopefully you can see it. This is a cross section of the left kidney. The right kidney is normal. I'm just showing one film, and I will show you the best film. And this is the mass in the upper pole of the left kidney. It is medially located. It's only about 1.6 centimeter in size. So the question is of the management option. How should we manage this thing? The first question is, does the patient need a biopsy of this mass? How should the patient be treated? But there's a typo. It is supposed to be active surveillance as the next option. It's not there, but the active surveillance is the next option. Should the patient have partial nephrectomy for this small 1.6 centimeter mass? Does the patient need a radical nephrectomy? Or does the patient need some less invasive procedure such as cryoablation or radiofrequency ablation? So please keep in mind that active surveillance is not, it's omitted, but it's unintentional. It is supposed to be there, active surveillance in there. Should I stop for a minute? And Dr. Kabir, what do you want? Do you want to ask the panelists how they want to manage this? Should I go to the next slide or?
Dr. Kabir, can I tell something? I will go for partial nephrectomy.
That's fine. That's fine. Anybody else? Anybody in favor of cryoablation or radiofrequency ablations?
So it is Dr. Kamal.
Yeah.
If I want to discuss with the patient for any reason, if the patient is unwilling to go for any surgical intervention, as a radiation oncologist, this patient can go for a stereotactic body radiotherapy. Now you know the data is quite fine with such a small size tumor with a very good survival and no detrimental effect to renal function. So I want to discuss with the patient. If there is an option of non-surgical intervention, I can go with it.
Dear Dr. Kamal, if you go for radiofrequency or cryoablation, before that you have to do the biopsy to confirm the diagnosis.
If it is a stereotactic body radiotherapy, definitely I need to know a tissue diagnosis before I go for non-invasive. Okay. I agree with you.
Come on, can you just tell us? Not very old, and there is no comorbidities. So partial nephrectomy is a very good option in this case.
I'm not disagreeing. I'm telling if the patient is reluctant to go for a surgery. Say, for example, for any reason, patient is not willing to go for a surgery, then this is an option. I'm not telling it, bring it in front. But yeah, I agree with you. If I go for radiotherapy, stereotactic body radiotherapy, I must have a tissue diagnosis, not biopsy. Even FNSC is fine because I not only it is a malignancy or not. Then I can go. Thank you.
Dr. Kamal, what is the current scenario of survival with this type of treatment?
Survival is very good. I mean, the data is not very large, but there is now 5 years data coming out, and it is quite comparable with radio RFA, and sometimes it is doing better. And the advantage of SBRT is that RFA has a limitation of size, but stereotactic body radiotherapy is treatable for bigger size also.
Dr. Jahangir,
yes,
this is Dr. Salam. I would like to express my experience. With this small renal mass, we had 3 cases almost very recently, almost for the last 3 years, we are keeping under surveillance, and those are the cases. One in bilateral kidney tumor, and another is CKD, etc., etc. We offered them the radiofrequency ablation. The patient underwent the radiofrequency ablation, and he is still under surveillance, and he is doing good. So from that viewpoint, radiofrequency seems to be safe, and they can be monitored, they can be reviewed, and if necessary, we can offer them partial nephrectomy anytime. I don't know what the board says. You can.
Actually, sir, in a fit patient, what is the best option?
Okay,
sir, I want to slightly add one thing, sir. So I want to point two things, that I am not bringing it as a gold standard or as an alternative. I was telling this patient is only possible if it is reluctant for invasive, and SBRT will be a only non-invasive procedure. Except the biopsy or FNAC, we shall not do anything, because in radiofrequency ablation, we need to put the probe inside, so it will be non-invasive. So that was my point. But again, I repeat, it is not a replacement of surgery or a gold standard here.
Okay, I am Professor Mofazzal. Can I add something?
Sure.
Right. Yes. Right. If you differ any aspect, then you can talk.
The problem is the main option in this case could be 1.5 centimeter tumor. She can be well followed up. Very close observation was a point, but unfortunately, the presenter has said that there is no option of observation. In that case,
no. So let me just
active surveillance.
No, it's not that. Probably he did not write that one.
It was not written. It is an option.
It is an option, but he said that.
But he probably presented, when he was presenting, he said that considering that these are the options. That was not the option, observation.
No, he said that is not written in the slide, but that is an option.
Right.
Probably
so 1.5 centimeter tumor can always be closely observed, right? If there is a progression, or having assumed that he has been well, the staging workup has been done, we consider if it is solid tumor, until proved otherwise, it should be considered as a renal cell carcinoma, if it is a solid tumor. But again, there are other possibilities also. That's why having so small a tumor, we can always put the patient on surveillance. 66-year-old lady, 1.6 centimeter tumor. Well, if someone wants to confirm the disease, then probably it's better to go for a FNAC followed by partial nephrectomy.
Okay, very good. So I think what I'll do, I'll address, because what happens is we have 8 cases to present. So I think we'll have to cut. Okay. So I think all of the opinions are really valid. And I apologize that active surveillance is supposed to be right after renal mass biopsy. So active surveillance is an option. So let me go to the next slide. So RMB is renal mass biopsy. So the patient had a renal mass biopsy done in October of 2018. And what they found at that time was papillary renal cell cancer. That was the diagnosis. Papillary renal cell cancer type 1. So again, I will just tell you about it. So what is the definition of a small renal mass? The definition is it is incidentally detected, just like this patient. It should be contrast enhancing solid or a complex cystic lesion, and it should be either 4 centimeter, less than 4 centimeter. Consistent with the clinical stage T1A, that's a less than 4 centimeter tumor. That's what this patient has. So this patient fits the definition of a small renal mass. And the question is selecting patient for initial active surveillance. AS stands for active surveillance. So you can always select the patient for active surveillance for a period of time. And if you see there is growth in the size of the patient, you can always change your mind. There is nothing you really lose. And that's one of the things I'll show. So whenever you are selecting patient for active surveillance, that you are going to do nothing but watch the patient closely, there are certain patient-related factors we look at it, such as age. In this case, the patient is 66. What are the comorbidities? Does she have any significant comorbidities? This patient does have diabetes mellitus that can affect the kidney function in the future. She does have hypertension that can affect. And we should always look at what is the baseline renal function. And the baseline renal function meaning what is the glomerular filtration rate. And when we treat patients with renal cell cancer, every patient should be assigned a CKD stage. Yeah, CKD stage. So that's one of the things we look at. So the reason I think it becomes important, what happens to this patient? What is the cause of death? And they looked at cause of death in patients over 75 treated for clinical stage T1, node negative renal masses. These are all patients which were treated either by radical nephrectomy, partial nephrectomy, or active surveillance. These are all patients with T1, meaning 4 centimeter or less mass. So when you did a partial nephrectomy, that total of 537 patients, 284, 53% of the patient had partial nephrectomy. The cancer-specific mortality is only 4%. This is over a 7-year follow-up. But the overall mortality during that time was 19%. So if you did a partial nephrectomy, cancer-specific mortality is excellent. But 5 times more patients died of other cause. Could be cardiovascular disease, stroke, whatever it is. So many patients die not from kidney cancer, from other related disease. So that's why it becomes important that we consider the comorbidities. When you did radical nephrectomy, they had 145 patients. 9.3% of the patient died of kidney cancer, but 3 times more patients died of other causes. Radical nephrectomy, if you look at the death rate, is higher. Likely the tumors were probably more larger, probably more close to 4 centimeters. Patients who had active surveillance, they had 108 patients. Cancer-specific mortality in 7-year time was 5.8%. But the overall mortality was almost 6 times higher. What does this slide tell us? That many patients with small renal mass, they do not die of kidney cancer, they die of unrelated cause, could be cardiovascular disease, hypertension, stroke, and other things. A similar study, these are cause of death in patients over the age of 66 treated for kidney cancer with surgery and pathologically node negative status. These are node negative patients. And again, you look at the same thing. The cancer-specific mortality is low, but the other cause mortality is almost 2 to 3 times higher. In 10-year time, 11.9% of the patient died of kidney cancer for tumor less than 4 centimeters. 4 times more patients died of other causes. That many of these patients with small renal mass not necessarily die of kidney cancer, they die of other causes. And that's why we always need to keep in mind the comorbidities. The other thing you talked about, that we should always know what is the baseline renal function before we did anything. Because let's say if somebody ends up doing a radical nephrectomy on this patient, or does a partial nephrectomy with prolonged warm ischemia time, and there is damage to that left kidney, what is the effect of chronic kidney disease? And what is the risk of death from cardiovascular events and hospitalization? So if there is chronic kidney disease, the risk of death, cardiovascular disease, and hospitalization will increase. And I will show you this picture. And basically this tells, these are patients with normal GFR over 60 ml per minute. This is between 45 to 59 GFR. This is 30 to 44, 15 to 29, and under 15. That these are patients are almost dialysis patients. So, and you look at this death from cardiovascular event, hospitalization, everything increases as the renal function deteriorates. So that's why nowadays you're going to be extremely careful that not to do a radical nephrectomy for these small renal masses. That's the key point in this one. You can treat it in other ways. Active surveillance is definitely an excellent option on this patient. It's a small renal mass. The patient is 66. She has some comorbidities. Active surveillance will be a good option. The patient may not want active surveillance. In that case, you can do a partial nephrectomy, and that will be a perfectly reasonable option. What will not be a reasonable option is to remove the whole kidney and just be based on that single right kidney. When we decide to put patient on active surveillance, we should always look at the size of the tumor. The tumor should be less than 4 centimeters in size. A lot of people will tell it should be less than 3 centimeters. Some will say really it should be even under 2 centimeters. But the accepted will be up to 4 centimeters. So if the tumor is too large, like in this patient, that patient is not a good case for a active surveillance. This patient, the tumor is encroaching into the renal sinus, not a great case for active surveillance. The risk is pretty high that the patient will start a hematuria at some point. And if you did a biopsy, you look at the biopsy. Is it a low-grade tumor or high-grade tumor? If it's a high-grade tumor, patient may not be an ideal candidate for surveillance. On the other hand, if the patient has oncocytoma, chromophobe, it'll be an ideal candidate for active surveillance. When do we decide? If we put the patient on active surveillance for SRM, meaning small renal mass, we are taking the risk from the patient. We are telling the patient that, listen, we're going to watch you, but it is our responsibility as urologist and oncologist that we make sure that we observe that patient very, very closely, because we got to make sure that the growth rate of this mass is not more than 0.5 centimeter per year. If it is more than 0.5 centimeter per year, the growth rate, maybe the patient should be switched to a treatment, whether partial radical nephrectomy or any other treatment we want. If the tumor becomes over 4 centimeters over time, that might be a time to do something. If the biopsy result is high grade, these are patients probably not ideal for surveillance. Or if the patient has hematuria, that means these are patients, the tumor is breaking into the collecting system, and I think those patients should be treated appropriately. Or the patient may change in mind. The patient might say, listen, I'm going to be on active surveillance 2 years down the road. They may not want to continue with the surveillance. If the patient decides to change, then I think the patient should be treated at that time. How should we follow this patient? If there's a small renal mass, like this lady with a 1.6 centimeter mass, for first year, we should follow the patient every 3 to 4 months. You could do just a simple ultrasound of the kidney and measure the size. If the mass is getting bigger too fast, that means the growth rate is over 0.5 centimeter per year. That might be a trigger for intervention. Year 1 to 2, every 4 to 6 months. After 2 years, the patient can be followed. As long as the mass is remaining stable in size or minimal growth, you can do the surveillance every 6 months. Most of the time, preferably, you can use ultrasound if it can be seen well, or you can use any other modality such as CT or MRI. So if you look at the AUA guideline, what are the ideal patient? I'll go to the next slide, and this is the patient-related factor. Favor active surveillance. When is right, active surveillance is right, if the life expectancy is low, that means elderly patient, high comorbidities. We talked about that many of these patients with small renal mass don't die of kidney cancer. They die of other comorbidities. And the poor functional status, that means the patient Karnofsky performance status isn't good. I think those patients can be surveyed. Or marginal renal function. The renal function is, the GFR is low, especially under 60 centimeter, 60 ml per minute. We always got to look at the tumor factor. Is the size of the tumor is over 3 centimeter? We have to be careful when you put the patient on surveillance, especially if it's between 3 and 4 centimeter. we try not to surveil patients who are over 4 centimeters. How does the tumor look in the CAT scan? Does it look infiltrated? Does it look it is infiltrating the renal parenchyma? If we did a biopsy, is it a low-grade tumor? Low-grade umor you can surveil, obviously. I will finish the first case. So, a take-home message for me, at least for the last patient, will be, if it's a small renal mass, patient is 66, patient is willing to be observed, we can observe the patient for a period of time. If the growth rate is more, we can always go into intervention at that point on this one. Dr. Kabir, should I move to the next patient?
Yes, sir. I think plenty of patients.
And we can go back, always discuss this again in this one. Okay. So this is a patient, case number 2. PE is the abbreviated name of the patient. This patient is also a female, a 70-year-old female patient. The patient has an incidental approximately 4.3 by 3.5 centimeter, again on the left side, left upper pole mass. The past medical history, the patient has hypertension, hyperlipidemia, atrial septal defect, and arthritis. Atrial septal defect is small, it is asymptomatic, no intervention is needed. She has mild degree of arthritis, her renal function is normal, the GFR is over 60 ml per minute. So although the patient is 70, the mass is the maximum size is 4.3 centimeter, but the renal function is good and no significant comorbidities. Her hypertension is well controlled. So I'll go to so this is an MRI picture. It's a 4.3 centimeter left upper pole mass. There's a small amount of macroscopic fat, but it is not an angiomyolipoma. A lot of time renal cell cancer will have a small amount of fat, but these are not angiomyolipoma. The bulk of fat is very small. And patient also has multiple bilateral renal cysts in this patient. So I'll go to the next slide and I think it'll show you a little better. So if we look at this one, this is the right kidney. This is a cyst in the upper pole of the right kidney. This is the left kidney right here. This is a cyst in the upper pole. And if you look at it, this is the mass. I'm going around the mass. This is the size of the mass. So as I told, the maximum dimension from here to here is 4.5 centimeter. If we look at this, this is part of the collecting system, renal sinus fat, you are saying, renal sinus fat. So that means it is pretty close to the sinus of the kidney right there. So the question will be, how do you treat this patient, right? And I think, again, I'll go to the next one. So these are the management options in this patient. Should we do a biopsy of this mass? Should we do active surveillance? Now remember, we talked about the definition of small renal mass. Under 4 centimeters, this is 4.3 centimeters. See, that's already a reason not to do the surveillance. Is this patient a good candidate for a partial nephrectomy?
Absolutely.
Should the patient have radical nephrectomy? And we talked about it.
May I request our panelist, urologist first, and Professor Khan is there or not? Or Professor Pranashish Shah?
Yes, I am here. Dr. Jahangir. I think this is a good candidate for treating with partial nephrectomy.
Right.
So I will totally agree. Partial nephrectomy will be an excellent option. Again, take a look at this one. When you do the partial nephrectomy, it will be pretty close to the sinus, right? But even then, I think it is a good candidate for partial nephrectomy. I agree with Dr. Shah. Okay.
Right.
And again, we have to be careful that when you do the partial nephrectomy, there is an appropriate surgical management of the case, vascular control. Do we need a 2 centimeter margin in renal tumor? We do not need a 2 centimeter margin in renal tumor. We need a clean margin. It could be 1 centimeter, but it got to be a clean margin free of tumor. So margin has to be free on this one. The second thing we always got to worry about in a partial nephrectomy, that we are not clamping the renal artery for a prolonged period of time, that it will cause warm ischemia. So in this case, I agree with Dr. Shah, partial nephrectomy will be a great option as long as we are making sure oncologically there will be a free margin. It doesn't have to be 2 centimeters, and warm ischemia time is less. I will always be concerned that doing a radical, we used to do radical nephrectomy in all of these patients. Radical nephrectomy is not an option really on this patient if you look at the AUA guideline, because many of these patients will end up with chronic kidney disease, which affects their lifespan on this one. Dr. Kabir, should I go to the next slide?
Anybody differ? May I request other oncologist, Dr. Kamal or Dr. Mohammad Hossain, do you disagree with this comment, or just we can go ahead?
I fully agree with the recommendations.
All right, Dr. Kamal.
Sir, please go ahead, sir.
Okay, thank you.
Very good. So these are the options, and I'll tell you why. These are cases, not necessarily. This is not my case, so I'll tell you what was done. So this patient had a partial nephrectomy, and the patient has done very well. So we always got to look at the risk of metastatic renal cancer according to tumor size. Larger the tumor, the more likely the patient will have either nodal disease or metastatic disease. So the size of the tumor has an influence of how well the patient will do. This is a study where they looked at 2,691 patients, all treated surgically, radical or partial nephrectomy, between 1989 and 2008 on this one. Of those 2,691 patients, synchronous metastasis, that means metastasis found at the time of diagnosis, time of initial presentation. They had 162 patients had metastatic disease at the time of diagnosis. Only one of 781 patients, they had 781 patients where the tumor size was less than 3 centimeters. When the tumor size is less than 3 centimeters, only one of 781 patients had synchronous metastasis at this one. Asynchronous metastasis, meaning that the patient developed metastatic disease during the follow-up, and the follow-up on this patient, as you can see, was from 1989, a long follow-up. 171 patients developed metastasis during median follow-up of 2.8 years. Only one of 720 patients with RCC less than 3 centimeters developed metastasis at the time. De novo, I think that's a type of de novo metastasis. So that means the small renal mass is very unlikely to metastasize. That's the point in here. But as the tumor gets larger, so if you look at, if the tumor size is less than 1 centimeter, between 1 and 2 centimeter, between 2 and 3 centimeter, the chance of metastasis is almost 0. As the size becomes 3 to 4, 1.8%, 4 to 5 centimeter, 2.3%. And if the tumor size is over 7 centimeter, the risk of synchronous metastasis at the time of diagnosis is close to 17%. So size of the larger the tumor, the more likely the patient may have synchronous metastasis. Same thing, what about the asynchronous metastasis during follow-up? And again, you look at the size, 1 to 2 centimeter, 2 to 3, 3 to 4, 4 to 5. And larger the tumor, the chance of asynchronous metastasis could be up to 20% for a tumor over 7 centimeter, between 6 and 7, 12 centimeter. So that means even with a T1 tumor over a period of follow-up, and this is 12% of the patient at follow-up. So the size of the tumor does matter. The larger the tumor, more likely is the risk of metastasis. But keep in mind, the risk of synchronous or asynchronous metastasis in small renal mass, 4 centimeter less, is extremely low. We'll go to case number 3. So the case number 3 is a relatively young man. He's a 52-year-old guy. He is an asymptomatic, incidental, 3.1 times 2.3 times 2.7 centimeter solid mass. His creatinine GFR is normal, over 60 ml per minute. But look at the past history, past medical history. Although he is 52, he has history of atrial fibrillation. That means he is on anticoagulant. He has history of supraventricular tachycardia, hypertension, and diabetes mellitus. So even though the person is 52, he has multiple significant medical problems, including atrial fibrillation, for which he is on anticoagulant. This patient, I'll take you down, he had a renal mass biopsy, and the biopsy showed benign renal cortical and medullary tissue. So this is again, I'll point it out, it's not very well, this is about the mass right here, in the middle of the kidney on the right side, left mid-pole renal lesion. So when we do the biopsy, we can find any of this. We can find clear cell cancer most of the time. We can find papillary type 1, papillary type 2, chromophobal oncocytoma. So all of these things are possible on this one. So what I'm trying to get to on this one, what is the diagnostic accuracy of a renal mass biopsy? Then what is the risk of biopsy in the diagnosis of renal mass suspicious for localized renal cell cancer? And this was published in May 2016. It's basically a meta-analysis. And if you look at the meta-analysis, they looked at all patients who had renal mass biopsy between 1997 and 2015. The total number of studies they looked at is 20 studies. And the total number of biopsies done, 3,113 in 2,979 patients. That means some patients had more than one biopsy. So what you really should find out, what is the non-diagnostic rate? Because that's one of the reasons which we always talked about, that we don't do biopsy because a lot of time it is non-diagnostic. In there, it's not a single center study, multiple centers all over the world. The non-diagnostic rate was 14.1%. False positive rate, that means the patient did not have renal cancer, but the biopsy was red renal cancer, was 4%. But the biopsy, 90% of the patient where the biopsy was positive and the patient had surgical excision, partial or radical nephrectomy, the biopsy was correct in over 90% of the patients. One of the things we always talk about that we don't do the biopsies because there is a potential for complication, which is correct. But the rate of complication in those patients, and this is not a single center study, it is from all over the world, 3,113 biopsies. The risk of hematoma, finding a hematoma around the biopsy site, is about 5%. Pain, 1%, gross hematuria, 1%, pneumothorax, 0.6%, and hemorrhage needing transfusion, 0.4%. That means the biopsy is quite, the risk of biopsy is quite low. And most of the time the biopsy will give you a diagnosis. But should we biopsy every patient with a renal mass? The short answer is no. We should not biopsy. We should be very specific when the patient should have the biopsy. And this is, if you look at the 2017 AUA guideline, and it will tell you right here that which patients really should have a renal mass biopsy. And let's just go over that one. Renal mass biopsy should be considered when a mass is suspected to be hematologic, such as, let's say you find somebody has lymphoma with involvement of the kidney, you are suspecting, the biopsy might be very helpful, that the patient can be treated medically. If you think there is a metastatic deposit in the kidney, let's say from the breast cancer, a tumor deposit in the kidney, you are suspecting, biopsy can be helpful. Beyond this, or let's say you might find an infectious mass, XGP, and there is suspicion, is it tumor, is it infectious? You can do a biopsy. Beyond this, that is the second one, is the important point. Beyond this, renal mass biopsy, RMB stands for renal mass biopsy, should be obtained on a utility-based approach. Is it going to help you if you do the biopsy? For instance, RMB, renal mass biopsy, is not required. You don't need to do a biopsy in young and healthy patients who are unwilling to accept the uncertainties associated with renal mass biopsy and follow-up. They don't want surveillance, they want to have treatment. Why do the biopsy? Or the patients is quite old, and the patients may have other significant comorbidities, as we talked about it. And maybe those patients do not need to have the biopsy. So when we do the biopsy, we always got to think, based on the result, is it going to make a difference how I'm going to treat it? If it doesn't make a difference, the patient does not need a biopsy. Let me go back. Should we have any discussion on the renal mass biopsy, or should I go to the next case? Dr. Kabir?
Yes, sir. I think now there's one point is there any decision about the type of tumor like papillary cancer or clear cell cancer? Does it change the scenario of observation and interventions?
Right. So it might change. Let's say you find an oncocytoma, right? An oncocytoma is a benign tumor, and the risk of metastasis is almost zero. And you can follow those patients if an oncocytoma. If you find, some sort of just an adenoma kind of thing, or a very low grade, which people don't read it anymore, as most are read adenocarcinoma, it might make a difference. So if you find a oncocytoma, I think it will make a difference. And the difference in the sense, the follow-up does not has to be, you don't have to do it every 6 months. Maybe you can extend the time between the imaging studies. So in some cases, if you think the biopsy is going to make a difference, you should do the biopsy. If it does, if not, you're going to do anyway. An elderly patient, you're not going to do anything. You can move on this one.
So why not FNAC? Why biopsy?
Why not FNA? Absolutely, I think so. One of the things is a lot of people will say the risk of putting the needle in and taking a coat of tissue may not be much difference. If the FNA, if the pathologist is comfortable making the diagnosis on an FNA, I think FNA will be a perfectly fine. That's been practiced in large part of the world.
Dr. Jang, can I ask a question to Professor?
Yes, sir, go ahead.
The question is, when a decision of radical nephrectomy is being made, is it sometimes very much important that we should know the diagnosis beforehand with a core biopsy?
No. So if you remember, so most of the radical nephrectomy you are doing either because you are highly, there's a large tumor, and many a time these large tumor are enhancing mass, right? Because renal cell cancer is a radiologic diagnosis, right? It's a radiologic diagnosis. Most cases we do not need to confirm. We should only confirm if there is doubt, right? So you may be thinking that maybe is it a oncocytoma? Maybe I won't do anything. I won't do a radical nephrectomy. I think biopsy would make an absolute difference in those cases. But most cases, it's a radiologic diagnosis. It's a radiologic diagnosis. Okay, we'll go to the next one. So this is the case number 4. It's a 55-year-old male. And in this case, incidental finding of 2, not 1, 2 asymptomatic renal mass, both in the left kidney. 2 asymptomatic renal mass in the left kidney. Past medical history is significant for hypertension, diabetes, and history of kidney stone disease not active right now. He did pass a kidney stone from the right side. That's the only past history. Renal function is normal. His GFR is again over 60 ml per minute. But he has hypertension and diabetes, which are well controlled. So I will show you this one. So this is a cross-sectional view, as you can see. This is the right kidney. You could see he's a fairly big guy. This is a right renal cyst. This is not a tumor. This is a right renal cyst. You go on the left side and you see there is a large cystic lesion on the anterior aspect of the left kidney. And if you look at it, the wall is thickened, it enhancing, and there are septi inside this one. So this will be considered a Bosniak class 3 cyst, right? Bosniak class 3, 50% of them have tumor and they should be surgically removed. But this is not the only tumor on this guy. I'll go to the next one, next slide. So this is one, keep in mind. And this is the second tumor in the same patient, somewhat posteriorly. There is an approximately 3 centimeter mass on this one. The right kidney, aside from that cystic lesion, there is no other specific lesion in the right kidney, will be considered normal. Okay. So he has 2 lesions in the left kidney, no lesion on the, there is a cyst in there. He has history of kidney stone disease, at least he passed 1 kidney stone. He has history of diabetes, history of hypertension, even though they are well controlled. And the solid mass right here measures 3.4 by 3 centimeter. Okay, and so there are 2 lesions. One is that Bosniak 3 lesion, and one is this lesion. So the question is, how will you manage this patient? So I will, I think I have the list on this one. One, is this a patient for active surveillance? No, he has multiple renal lesions. There is a solid lesion, and there is a Bosniak 3 lesion, which is quite large. So not for active surveillance. The question on him will be, should he have a radical nephrectomy because he has multiple, more than 1 left renal lesion? Or should he have partial nephrectomy, remove those 2 lesions, 1 cystic lesion and 1 solid lesion? Yes.
Do you consider other tests of multiple, in case of multiple lung tumor, like genetic analysis or anything like that?
Right. So again, the multiple renal lesions, I think that's what you're talking about. Should you have genetic testing? Not everybody, but certain patients, such as if the patient is younger than 46 years of age, they should have genetic testing, irrespective, even if they're just single renal mass. I think they should have genetic testing for younger patient on this one. Multiple renal lesion. Remember, these are not both solid renal lesion. One is a cystic, one is a solid lesion. So it's unlikely, but genetic testing will not be unreasonable doing it in this case. So I'll go to the next one. So these are the options. Active surveillance. I don't think this is a good candidate for active surveillance. Partial nephrectomy, remove the 2 tumors, or should you have radical nephrectomy? That's what you have to decide. Radical versus partial nephrectomy, because he has multiple renal lesions. So Dr. Kabir, go ahead. I think we'll open it up for discussion.
Right. Who's going to volunteer? May I request?
I will go for partial nephrectomy. Dr. Kabir, I am Dr. Ehtishamul Haq. I will go for partial nephrectomy.
That's fine. If it's possible, then partial. I also prefer partial nephrectomy. Anybody else? Anything?
I think a lot of people will consider partial nephrectomy. Remember, he has history of kidney stone disease. So if we take 1 kidney out, he has 1 kidney. Yeah, number 1, he'll have CKD. He already has diabetes and hypertension. They may not be bad right now, but over time, they might affect his kidney. So I think saving part of his kidney, I think, will be a very reasonable thing to do for most people.
That's a reasonable point. Anybody differ with these things or anything, want to volunteer or add anything? Professor Khurshid, do you want to take part in discussion? Hello, are you audible? I'm not.
Dr. Kabir, one point I'll always make. In this patient, when you talk to the patient, even though that's what I will do, I'll get a consent for partial nephrectomy of the 2 lesions. But I'll always make sure the patient understands that there is a risk that you will end up with a radical nephrectomy. And the patient must know that ahead of time, number 1. Number 2, how you approach this is depend on the experience of the surgeon. It can be done anywhere. There is nothing wrong doing a good open partial nephrectomy of those T lesions. If somebody is facile with a laparoscopic partial nephrectomy, perfectly fine. Robotic partial nephrectomy, perfectly fine. So approach depends on what is the best thing you can do for the patient. So this patient had 2 partial nephrectomy. The upper cystic lesion showed clear cell carcinoma, Furman grade 1, very low grade. So the Wozniak 3 was the Furman grade lesion. The lower lesion had left kidney. It's a partial nephrectomy, renal cell carcinoma, 2.6 centimeter greatest dimension, clear cell type, grade 2. And again, if you look at the specimen, there are many, many frozen sections done at the time of the partial nephrectomy. So one of the things we always should make sure when you're doing partial nephrectomy that the margins are negative. That's important, margins are negative. This is a patient, remember, he has 2 lesions. So warm ischemia time will be very important. How long should we keep the renal artery clamped? We try to minimize as best as possible, minimize the warm ischemia time. So this was done. I did it open, partial nephrectomy of both lesions, and the patient. So this is the question. The patient has done very well over the time. So this is the question on this one. What is the long-term outcome of multiple ipsilateral renal tumors found at the time of planned nephron-sparing surgery? If you find more than 1 tumor, should you do a partial or radical nephrectomy? And what they are looking at, what happened to the cancer-specific survival? On the top, NSS is nephron-sparing surgery and radical nephrectomy in multiple renal tumor in the same kidney. There is almost absolutely no difference in the long-term cancer-specific survival. So even if you find multiple tumor, you do not have to do a radical nephrectomy. If possible, do a partial nephrectomy because these patients do very well. They do just as well as a radical nephrectomy. So what is the AUA guideline for 2017 renal mass and localized renal cancer? That what is the partial nephrectomy and nephron-sparing approaches? This is what the recommendation is. You prioritize partial nephrectomy for the management of clinical T1, CT1, clinical T1, that means tumor less than 4 centimeter. A renal mass when intervention is indicated. If you're going to do active surveillance, perfect. If you're going to do radiofrequency ablation, that's different. As Dr. Kamal spoke about, stereotactic radiation therapy. But if you're going to do a partial nephrectomy, prioritize nephron-sparing approaches for patients with an anatomic or functionally solitary kidney. So if you have a solitary kidney, obviously you will do a partial nephrectomy. Or the other kidney is borderline functioning for other reasons, then we should do a partial nephrectomy. Consider nephron-sparing approaches for patients who are young, have multifocal masses, or comorbidities that are likely to impact renal function in the future. Diabetes, hypertension, cardiovascular disease. They may be perfectly normal renal function now, but it might be affected in the future. You got to think ahead of time that most of these cases, a partial nephrectomy is a better idea in this one. What are the principles related to partial nephrectomy we talked about? Always prioritize preservation of renal function. And again, unlike many other tumor in renal cell cancer, which has well-defined capsular marker.
You cannot hear anything.
You cannot hear anything?
Who is that?
Can everybody else hear me?
I think we can hear him, but
yes, it's clear.
it's clear.
You can hear clearly. That may be a local problem.
Maybe just make sure the microphone is not muted. Okay. So we should always look at a negative surgical margin should be a priority. We should always try to have a negative surgical margin. But in a partial nephrectomy for a well-encapsulated tumor, we do not need a big margin. You need a margin free of tumor So even enucleation is good enough as long as the margin is negative. I'm not in favor of enucleation. I always will do a partial nephrectomy with a negative margin. That's the goal. I'll go to case number 5. So this is now a much older patient. The patient is 76-year-old male. No significant past history. The guy comes in, and the only reason he comes in, he has bilateral lower extremity edema, more on the left leg than on the right leg. There is no other symptom. His creatinine is elevated at 2.06 mg/cent. He had CEA, PFA, FPHCG done are all normal. He had a CT abdomen done, and I'll show you the CT abdomen right in next one. It's a large retroperitoneal mass with left-sided hydro. So I'll show you the image. So this is the image you see on this patient. This is the liver, right kidney. This is the left kidney with some hydro right here. And this is a retroperitoneal mass, which is 16 centimeter across the board on this one. It appears that the left kidney is involved in the mass, and there is mild degree of hydro. And both the aorta and the vena cava you can see because they are all encased. So I think this will open it up really for, I think it'll be, if there are residents, they might be able to tell, give the differential diagnosis on this one, that what should we really be looking for when the patient presents like this. And many of these patients, this patient presented with lower extremity edema. Some patients present with the back pain in many of these cases. So if we have any residents, if they could tell the differential diagnosis. Dr. Kabir, you want to ask anybody specific?
I just question is open to everybody. Is there any possible differential diagnosis? Can you volunteer? Can anybody volunteer about this? The junior and residents, please come up. No.
So can I tell?
Sure.
Sure. I think it might be a case of whether there is any lymphoma.
Okay, so that's the diagnosis, absolutely. That will be really be on the top of my list. But let's say what other differential diagnosis?
Anybody says, please identify himself first and then tell. Then it's easy for us to recognize him. Anybody else other than lymphoma?
And Dr. Salam would like to speak a few words.
Yes, sir.
It can be a lymphoma, but the other possibilities are a renal cell tumor can invade the lymph node and can give rise to paraortic lymph node to that extent as well. Only in the last week we had similar cases. A tumor which is sitting in the midpolar region and has invaded the hilar lymph node, and that has extended in the paracaval lymph nodes, and ultimately the lymph node was so huge that lymph node is more palpable rather than the tumor itself. It is the CT scan which has given the idea. So renal cell carcinoma could be another option. Otherwise, de novo retroperitoneal sarcoma could be another option, or another possibility.
Right. So one of the things is for the younger residents, just keep in mind, if this is a younger patient or sometime maybe even older patient, always think of large retroperitoneal mass, testicular cancer, right? Always think of testicular cancer is one of the differential diagnoses. Occasionally, not very common, prostate cancer, bladder cancer can present like this. It's not common, but we got to keep it all in the differential diagnosis. So we'll start with the lymphoma on the top. Then we can talk about, renal cell cancer possible on this one. Definitely retroperitoneal sarcoma, testicular cancer, prostate cancer, bladder cancer, all of them can cause that on this one. And I think in these cases, many a time, I think it is better to get a good biopsy of this mass. It'll be easy to get a biopsy, and I think it will give you the diagnosis, and that can guide you the treatment really on this one. So this is one case where the biopsy is important. So I could.
Yeah, what are the biopsy results, sir?
I'm sorry?
What is the biopsy result?
Okay, so we'll go back to this one. So this is the next step. So this is the biopsy. Interventional radiology people do the biopsy in our case, and they go through a posterior approach. They take the mass biopsy, and the pathology was consistent with mature B-cell lymphoma was the diagnosis on this one. The CD, it's not CE, CD10 was positive, and it's appeared, at least based on the biopsy, they thought it's a lower grade disease, right? Lower grade disease. So again, differential diagnosis is, we talked about all of those: lymphoma, testis cancer, prostate cancer, bladder cancer, rectoperitoneal sarcoma, renal cancer. Okay. What I really want, so I think let's just stop for a minute on this one. So if this is a lymphoma, the patient should be treated like lymphoma, and the treatment of this is very effective. I'll stop right there if there is any comment.
Right.
Dr. Kabir.
Yes, please. Professor Mafazul. Professor Mafazul.
Yes, you muted me. I was about to tell something.
No, you can carry on.
Right. If it is a renal lymphoma, we call it extranodal lymphoma. Right. The prognosis of extranodal lymphoma is not that good. But if the tumor is not a big one, I mean what we call bulky disease, more than 8 centimeter, then the prognosis will not be that bleak. And the immunohistochemistry is very important in this particular case if it is lymphoma. If it is lymphoma, then we are going to treat with R-CHOP. That means rituximab along with standard CHOP. Maybe if it is a bigger one, then he may require 8 cycles. Otherwise, 6 cycles is the standard one.
I totally agree. And I think this is the message for the younger residents, younger attendings, that I think when we see something like this, that we do not go for surgical treatment right at the start. Try to get a diagnosis and look at the differential diagnosis, what else that could be, because the patient may have a much better treatment. In this case, chemotherapy will be an ideal treatment. One of the things we don't see is primary renal lymphoma. You can have secondary involvement of the kidney, like this patient had retroperitoneal mass going into the kidney. But there are patients who can present with primary renal lymphoma, although it is quite rare. Primary renal lymphoma defined as lymphoma arising from the renal parenchyma and not invasion from adjacent lymphomatous mass. We see patients like this, and a lot of time we think these are renal cell cancer, papillary type usually, and we usually go for some surgical treatment. We have to be careful that is it a lymphomatous involvement of the kidney? And I wanted to spend just the next few slides just to make sure we understand that. Okay. What is the best diagnostic test if we are thinking that the patient may have primary renal lymphoma? CT with contrast is the imaging of choice. If the patient has elevated creatinine, or you cannot do a CT for whatever reason, ultrasound, but MRI is better than ultrasound if you could do the MRI. FDG PET scan appears to be a good study, especially if you're looking for recurrence of the tumor. So how does the primary renal lymphoma looks? This is especially for the residents. So if you take a look, see this is a CT with contrast. This is the right kidney and the left kidney. And you see multiple of these relatively hypoechoic lesions in both kidneys in there. But one thing you see, it does not really deform the contour of the kidney. The kidney contour looks fine. If it's a renal cell cancer, usually it will deform the contour. When you lymphoma, it's a multiple renal lesion. They are relatively hypodense, and they do not deform the contour. The second, they do not involve the renal vein or the vena cava, usually this one. So and the enhancement is minimal, right? So remember, what other kidney tumors with minimal enhancement, sometimes it could be papillary renal cell cancer. So we want to make sure we are not thinking of papillary renal cell cancer. So a contrast enhanced, let me go back, a contrast enhanced CT with hypoenhancing soft tissue mass, they do not deform the contour, only minimal enhancement with contrast, unlike RCC, and renal lymphoma unlikely to involve renal vein or the IBC. So if you ever think of, should this patient have a renal mass biopsy? Absolutely, because this renal mass biopsy will give the diagnosis that if the patient has lymphoma, and the patient can be treated appropriately in those cases. You look at, again, sometimes you may have primary renal lymphoma with para-aortic lymph node, a para-aortic lymph node involved with lymphoma. So you can have large rectoperitoneal mass with involvement of the kidney like the first case. You can have primary renal lymphoma without any lymph node like the second case, or you can have primary renal lymphoma with rectoperitoneal lymph node. If you did an ultrasound, if you, for some reason you cannot do a CAT scan, this is a kidney ultrasound, and you look at multiple hypoechoic lesion. This is a cross-sectional view, and these are multiple hypoechoic lesion. If you did an MRI, can be equally diagnostic. You look at the left kidney with multiple hypoechoic lesion, similar thing in the right kidney in there. So we looked at the imaging patterns of lymphoma involving the kidney. Solitary renal lesion most common. Direct extension to kidney from a large rectoperitoneal mass, second most common, like our first case. Perinephric disease is perinephric soft tissue compressing normal renal parenchyma, like we had the third case in there. Primary renal lymphoma, a population-based study in the United States. That's how they look at it, that many of these patients will do relatively well. So the most common histology is diffuse large B-cell lymphoma in this whole study, and this is a SEER-based study, so it's a multiple center. It's very uncommon, but they had 723 patients over a long period of time. 1 year survival rate with chemotherapy, Dr. Mafazal told you, it was 78%, 5-year survival was 64%. Mean age was 63.7 years. It is more common in male than in female. 63% in male, 37% in female. I will stop there and hopefully have any comments.
May I ask the junior colleagues to tell me what should be the stage of the disease when there is diffuse involvement of the kidney, maybe a single kidney or maybe bilateral. What should be the stage? Any idea?
Anybody can volunteer the same questions. Just tell us about the things about the staging of lymphoma you are telling about.
Right. If there is diffuse involvement of any organ other than a lymph node, then we call it stage 4 disease. Diffuse involvement of extranodal organs like lung, liver, kidneys, if these are involved diffusely, as was shown in a picture involving the kidney diffusely, that should be stage 4. Despite that, one has to go for staging, further staging to see whether other organs are involved or not, whether the lymphoma primarily originating from the kidney or lymphoma elsewhere in course of time involving the kidney. The other important point is one has to see whether there is involvement of the bone marrow or not. This is very important. If there is involvement of the bone marrow, then in addition to the treatment that I already spelled out earlier, the standard R-CHOP, because most of the lymphomas are CD20 positive, so R-CHOP is the standard treatment. But if there is involvement of bone marrow, then in addition to that, the patient should also receive intrathecal methotrexate as a prophylaxis for CNS involvement in future. This is very important.
Very good point. Very good point. We just you appreciate that. And
so I think that was excellent, really, from Dr. Mufazzal. It's a summary of how the patient should be treated. And one of the main reasons I brought this up, because for the younger group, that not every renal mass is a renal cell cancer. We always got to look at the differential diagnosis. And I think we should have a fairly good understanding how to make diagnosis of primary and secondary lymphoma involving the kidney. I'll move into the case number 6. So the case number 6 is a 76-year-old male. And this time he has an asymptomatic incidental 3.5 times 2.4 by 2.2 centimeter solid right kidney upper pole enhancing mass. His past history is obesity, hypertension, diabetes mellitus, CKD. So he has multiple significant problems. Creatinine is 1.25 milligram %, although it's not bad, but the GFR is only 42 ml per minute. So he is a CKD, stage 3 CKD already when he presents in there. And I think if you look at the very bottom part, right, it says Jehovah's Witness, right? Jehovah's Witness is a religious group in the United States. And one of their tenet is of their religion, they do not accept blood transfusion. So whatever, even if they die, they will not accept blood transfusion. So you have to consider when you are thinking how to treat this patient, that this patient will not accept blood transfusion no matter what. So that becomes important as we decide how to treat this patient. So again, so this is a non-contrast study. The left kidney is normal. This is the mass in the right kidney in the upper pole, very close to the sinus of the kidney. This is, you can see the enhancement of the mass, and the enhancement went from 45 to, I believe, over 100 in there. So this is an enhancing mass in the upper pole of the right kidney, approximately 3.5 centimeter, pretty close to the sinus in there. I think I'll come back to this one. So I think, what is the treatment option for this patient? Remember, so this is a guy who has about a 3.5 centimeter mass, and he has some medical issues, including he will not accept blood transfusion, this one. So these are the options. Active surveillance could be an option. Renal mass, should you do a biopsy, partial nephrectomy, radical nephrectomy, radiofrequency ablation, or as Dr. Kamal said, stereotactic radiation therapy. What should we do? So it's not, let me move just to the next one. So what the patient had. He had a CT-guided biopsy. So remember, he came in December 2016. The next month, January 2017, he had a biopsy. And the biopsy showed renal cell cancer clear cell type. Now, should the patient have a biopsy? This is not my patient. It was presented from one of our affiliated hospitals. And I thought the biopsy is reasonable on this patient because he has multiple comorbidities, right? If you did a biopsy and the biopsy showed a benign tumor, which is about 20% of the time the tumors could be benign, then maybe he doesn't need anything done because you want to avoid surgery in this patient with multiple significant comorbidities in this. Plus, he's 76 years of age, this one. So I think I'll open it up now, and maybe we should have, how should we treat this patient?
I think partial nephrectomy would be the best choice from my viewpoint.
Right, so partial nephrectomy definitely will be an option in this patient. What else?
Well, it should be an open partial nephrectomy because this guy does not actually accept any source of bleeding.
Right, and I think a lot of people will agree with that. And so I think the open laparoscopic or robotic, that's a choice by the surgeon. I think anybody who is specialized in whatever they do, I think you should do what you are most comfortable with. That's the whole thing. The goal, remember, of a partial nephrectomy a clean margin and reduced warm ischemia time. Those are the two goals. As long as you can do the goal, whatever approach you like, I think is very reasonable on this one. Any other thoughts how this patient should be treated?
Jahangir.
Yes, please.
Active surveillance may be one of the options in this case is elderly, 76 years with comorbidity.
Right. So I think that will be a very reasonable option. Remember, it fits into the criteria. It is less than 4 centimeter, correct? It is less than 4 centimeter. It is well encapsulated into the kidney in this one. It's 77. He has multiple comorbidities. I think active surveillance will be a very reasonable option. And again, active surveillance doesn't mean you can continue it for 10 years. You might do it for 2 years and you see there is increase in size of the mass, you change your mind. You know what I mean? But again, if you decide to do active surveillance, we take up on the responsibility of following the patient closely. If the patient is not going to show up, I don't think the patient is a good candidate for active surveillance. So I will agree active surveillance is an option, partial nephrectomy is an option.
Right, sir. We have some comment.
Sure.
Sir. We have some comment. Yes. One thing is that Muhammad Ali, probably he's from UK now. He used to be here, but he's UK now. He's working there. He said active surveillance, cryo, RFA, or maybe try besides partial nephrectomy. Do you consider?
I totally agree. So I think radiofrequency ablation or cryoablation will be very reasonable option in this patient. So I will show you what was done.
Another question is here. I mean, should we go for frozen section in case of partial nephrectomies? It's a general question that whenever
So the patient, when they have partial nephrectomy, they should have frozen section to make sure, because remember, one of the main thing we want, if we did a partial nephrectomy, a negative surgical margin, we want a negative surgical margin. So yes, frozen section.
This was a question from Dr. Kamrul to you.
Sure.
Right. So go ahead, sir.
Okay. So this was, the patient underwent radiofrequency ablation, and this was done, remember the biopsy was done in January 2017. He had the RFA, radiofrequency ablation, done on January 22nd, 2017. But the problem was the patient was lost to follow-up. So that's the problem. If we do a RFA, the patient got to be followed closely, just like an active surveillance. You got to make sure, did you cure the patient? Is the mass still there? Is the mass enhancing? Is the mass getting larger inside? So the patient was lost to follow-up. He came back August 2018, that means almost a year and a half later. He remained asymptomatic and his creatinine was the same as before, GFR about 40 ml per minute. Now I will go back in August 2018. Let me just see.
Yes, same.
Okay, so this slide, this is the slide from August 2018. He came back and you see the mass still there. A year and a half later, the mass is still there on the right upper pole. Maybe the mass is a little larger. Now it measures 3.9 centimeter enhancing mass, right kidney upper pole, right? So the thing has gotten bigger than a year later. So I will go back. What else did it show? It shows also a small thrombus in the left renal vein now. A thrombus where the left renal vein goes into the IVC. There is a small 1 centimeter thrombus at the junction of the right renal vein and the IVC, plus multiple small pulmonary nodules. So right now, the patient has not only what appears to be a progression of disease in the right kidney locally, there may be a little thrombus in the renal vein at the junction of the inferior vena cava, and multiple pulmonary nodules. So this patient, obviously, we didn't serve him well. You know, he probably would have done much better, I will guess, with with partial nephrectomy. But you know, because of all the comorbidities, he had the radiofrequency ablation. Obviously, the patient was lost to follow-up for a period of time. Now he has recurrence. He has evidence of pulmonary metastasis in there. So the question is, what do you do now? You know, that's where the patient is right now.
Right. So, any oncologist is joining here? Do they have any proposition?
Sir, if I'm allowed, I want to go back to this case that last time Dr. Jahangir was asking me about the survival. So if this case was not in 2017 in the US at Professor Chaudhary Center, it was in 2020, I'm sure this patient would have been offered a stereotactic body radiotherapy, not radiofrequency ablation, because the biggest challenge of RFA is after doing RFA, you need to do a biopsy to confirm, because a good number of percentage it is not tumoricidal. But in SPRT, you are not doing that. And the data is the cancer-specific survival of SPRT in this type of tumor is 94 to 97% in 4 years' time, which is equally comparable to surgery. So the outcome is fairly better. So this was my comment on the previous situation. So now we have enough data to say that this type of tumor is doing better with radiotherapy. And here, of course, unfortunately, as the patient has progressed to metastasis, so the patient will need treatment, but now we need to categorize him whether he is in low, intermediate, or high risk group. And according to risk stratification, we can offer him TKI, but we know now that the combination of immunotherapy is doing better than TKIs.
Right. So I think what I will do, so I think the point we make in here, if you do an RFA active surveillance, I think the follow-up is critical, just like Dr. Kamal was saying, that this patient, he was scheduled for a biopsy in March of 2017, and he did not return for follow-up, but this is where he is right now. Okay, so what are the treatment options? Should he have radical nephrectomy with immunotherapy on that side? Because now, not only has the mass in the recurrence, he also has a thrombus at the junction of the IVC and the renal vein. Should he have neoadjuvant immunotherapy, like what Dr. Kamal is suggesting, and then maybe radical nephrectomy? Or should he have immunotherapy alone in this case on this one? So again, this patient had immunotherapy and he's still being treated. So I'll go back to thermal ablation. What does the AUA guidelines say about thermal ablation? So the physician should consider thermal ablation as an alternate approach for the management of CT1A renal mass less than 3 centimeters in size. So this is a case for the thermal ablation will be a reasonable option because of all the comorbidities on this patient. For patients who elect thermal ablation, a percutaneous technique is preferred over a surgical approach whenever feasible. You could do it laparoscopic or otherwise, but percutaneous approach is preferred. And one of the things they talked about that both radiofrequency ablation and cryoablation are options for patients who elect thermal ablation on this one. More important, counseling about thermal ablation should include information regarding an increased likelihood of tumor persistent or local recurrence after primary thermal ablation relative to surgical extirpation or other treatment, like Dr. Kamal is pointing out, that I think if you decide to do it, you're going to tell the patient that these are the risks on this patient. Now, there is a study which was not in a human study. This was done in animal model. And one of the things they're trying to point out that when you do thermal ablation, sometimes maybe the cancer cells become more activated and more of a risk. This has never been proven in human, but this was a study in 2012 in animal study. All right. I'll go to case number 7, this one. And this is a guy who presented with a large left upper pole renal mass. You look at this one. This is the best slide I could find. It goes almost to the middle of the kidney in right here up to this point. He presented with hematuria, but by the time he came in, the hematuria had stopped. He had no other symptoms. Physical exam is unremarkable. The guy is 38 years old. He's 38 years old. Okay. So this is a patient because I think they looked at, can they do a partial nephrectomy, and partial nephrectomy was not feasible just because the mass was in the sinus close to the hilum, and they ended up doing a radical nephrectomy. And this is what the AUA guideline says about 2017. So there is a big difference in the guideline. And one of the main things the guideline is trying to tell in 2017 that radical nephrectomy should be used with very strong indication. In the past, we did radical nephrectomy a lot of time for small renal mass, and that should be avoided as much as possible. So this is what the guideline says about radical nephrectomy. Physicians should consider radical nephrectomy for patient where increased oncological potential is suggested by tumor size. Oncological potential meaning recurrence, metastasis because of the size of the tumor, and this one. Renal mass biopsy and or imaging characteristics. Let's say the renal mass biopsy, if we did a biopsy, it showed high-grade tumor. Or imaging characteristics, and I'll show you some of the slides where it might look like that these may not be ideal candidate for partial nephrectomy. So let's say in this patient, this is a mass, this is a separate patient, which is essentially encroaching into the sinus. Partial nephrectomy is feasible, but I think it'll be very challenging. In this one, the right, there's a mass, and I think partial nephrectomy probably will be an impossible task in this patient. So if the complexity of the tumor shows it is not a case for partial nephrectomy, radical nephrectomy can be done. So it's not that we should not do radical nephrectomy at all, but we should do it with strong indication. So high tumor complexity and partial nephrectomy would be challenging even in experienced hand. There is no pre-existing CKD or proteinuria. If that is the case, they are more likely to have adverse impact longer term because of the CKD, high cardiovascular events and things like this. And when there's a normal contralateral kidney, you got to have a normal contralateral kidney and a baseline GFR. At the end of the nephrectomy, you should be expecting over 45 ml per minute. So this is the guideline statement number 19 regarding radical nephrectomy. Physicians should consider radical nephrectomy for a patient with a solid mass, like this patient, or a Bosnia 3/4, that means complex cystic lesion. Those patients can have radical nephrectomy where increased oncologic potential is suggested by tumor size, renal mass biopsy imaging, we already talked about. And increased oncologic potential, meaning risk of metastasis to the lymph node or risk of metastasis itself happens. Increased by tumor size, we talked about. Larger the tumor, more likely to have metastasis. If you did a biopsy and it shows high-grade tumor, or in the CAT scan, MRI, the tumor does not have a clear capsule, it is more infiltrating, then more likely you will end up with a positive surgical margin with a partial nephrectomy, or it's a locally invasive features. Okay. Let me go back. Okay, so that's for radical nephrectomy. Should we move on, Dr. Kabir, or you want to stop?
I think go to the last question. Anybody any comment or any question on this up to this the cases we have discussed?
Dear Kabir sir, I want to.
Yes, please, sir.
I have a question to Professor Chaudhary sir.
Have metastasis.
Professor Salam sir, we'll have time in last for comment. Please,
okay. Thank you.
And
I have a question to Professor Chaudhary sir.
Yes, please.
Sir, after going through the cases you have discussed today, so far I understand that you are giving much importance on the size of the tumor, that is 4 centimeters.
Right.
Right?
Because the size of the tumor becomes important if you are thinking of one, active surveillance. That's one, because the tumor size should be really less than 4 centimeters if we decide on active surveillance. But there are other factors. Remember the complexity of the tumor, the age of the patient, the comorbidity, baseline renal function. These are all important. Size of the tumor is also important. If you are thinking of doing a partial nephrectomy, most people will limit partial nephrectomy to size of 7 centimeters. But obviously, people are doing larger tumor with partial nephrectomy, especially if there is a solitary kidney, abnormal other side. The size of the tumor is important for many different. That's not the size. The size.
My question is.
Sure.
So my question is, for the small tumor less than 4 centimeters, active surveillance in our part is not very easy. So rather it's very easy or logical to do the partial nephrectomy in those patients, particularly in our part. So what's your suggestion or comment regarding that?
Yeah, so that's an absolutely acceptable. You got to, so active surveillance really is a patient's choice. Patient has to tell, listen, I want active surveillance. I do not want to have any surgical procedure. Or the risks of doing a surgical procedure is too much in this one. So partial nephrectomy for most small renal mass is the most definitive treatment, right? As far as the cancer is concerned, that is the most definitive treatment. Radical nephrectomy could be even better, but radical nephrectomy has a lot of other side effects, right? Chronic kidney disease and other things. So partial nephrectomy, I think, is a good option for most small renal mass, especially if there is going to be challenge in following the patient. And remember, it's not only in Bangladesh, it's everywhere. Following the patient can be a challenge. And if there is any concern about the follow-up, they are better off with a partial nephrectomy. That's my opinion.
Anybody, any question? Because we are moving towards the last case. Professor Chaudhary is going to tell our last presentation. And after that, we'll have some comment from senior participants as well as junior question from the junior doctors. And then we'll have some comment from chairperson of the session.
So I'll go to the next case.
Yes,
so
sir.
the next case, though, is a more advanced disease. This is a 52-year-old male. When he came in, he already had metastatic disease involving retroperitoneal lymph nodes, abdominal metastasis. He came in from another hospital. He already had nivolumab as well as ipilimumab, nivolumab treatment. He was switched to Avastin in March of 2017. These are before he saw us in March 2017. In May 2017, he was admitted for abdominal pain after receiving those treatment outside. Urology was consulted at that time for a cytoreductive left nephrectomy. And this is the way I will take this one off. This is how it looks. It's a 9 centimeter left renal mass. The mass appears to be breaking through the capsule into the posterior abdominal wall in this area. There are lymph nodes in the retroperitoneum. Remember, that's the way he was diagnosed. He already had immunotherapy, checkpoint inhibitors for that time. Fairly extensive retroperitoneal lymph node, and he also has a left lower lobe lung nodule. This is a typo, so excuse me for that. So a left lower lobe lung nodule. So those are the findings he came in with, and they are basically asking that to do a cytoreductive nephrectomy because of the abdominal pain. He had no hematuria at that time, just abdominal pain on this one. So I think the question is role of cytoreductive nephrectomy in patient with metastatic renal cancer, especially in a patient who have already failed immunotherapy on this one. So is cytoreductive nephrectomy beneficial in advanced renal cell cancer? You can say the short answer is no, but it is not as clear. Probably the role is very limited in intermediate and poor risk disease. There may be some role in low risk disease. The trial called Carmena trial, and it showed, let me go over the details of the study. So this was comparing sunitinib alone a vascular endothelial growth factor inhibitor, or just do it before nephrectomy, or sunitinib after nephrectomy in metastatic renal cell cancer. This was a randomized phase 3 multi-center trial. There are 451 patients, 1-to-1 randomization. IVC tumor thrombus was not an exclusion criteria. When they looked at the median overall survival with sunitinib alone, patient before nephrectomy, just sunitinib, median survival was 18.4 months versus 13.9 months nephrectomy followed by sunitinib. The patient who had sunitinib upfront did better than patient with nephrectomy followed by sunitinib. Median progression-free survival for sunitinib alone was 8.3 versus 7.2 months for the surgery group. That means patient with sunitinib did better. Rate of tumor response to therapy was same in both groups. And the clinical benefit experienced by 47.9% of patients on sunitinib alone versus 36.6% in the surgery group. So the conclusion of the study was sunitinib alone was not inferior. It is a non-inferiority study. Was not inferior to nephrectomy followed by sunitinib in patients with metastatic renal cell cancer were in the MSSCC intermediate risk or poor risk group. So remember, that's the caveat, that intermediate and poor risk group, cytoreductive nephrectomy was not very helpful. But on the other hand, they did not look at patients with low risk group. And that still may be one area where cytoreductive nephrectomy may be helpful. I think this is the last slide. I will stop. We have a case number 9, but I can stop right there.
So, sir, do you have any more time, or just want to finish now? You can go for the.
Sir, can I ask a question? Jangir Kabir sir, this is Ibrahim Kai sir.
Please, carry on.
Hello?
Any question?
Okay. Okay. Maybe silly, but I need to ask it because I need to clarify it for better understanding. In some slides, Professor Chaudhary, you have shown that it's a de novo asynchronous metastasis, and sometimes you told synchronous metastasis. What does these two things mean?
Okay, synchronous metastasis will be that, let's say a patient comes to you with a renal mass, 4 centimeter. You do a metastatic workup, you find retroperitoneal lymph nodes, pulmonary mats, or something like this at the time the patient came in. That's a synchronous metastasis.
All right.
Asynchronous metastasis will be, you did the radical nephrectomy, the patient did perfect for 5 years. 5 years later, he has a pulmonary lung nodule. That's an asynchronous or de novo. It happened at that time. Some people will call it de novo. Some people will call it, I think asynchronous is a better term in that case. So one at the time of diagnosis, the other will be during follow-up.
Sure. Okay. Is there any term metachronous metastasis?
Metachronous will tell me that multifocal, there is multiple disease, multiple metastatic disease.
Thank you, sir.
Dr. Jahangir, can I ask a question to Professor Chaudhary?
Yes, please. Yes, please.
Dr. Chaudhary, would you please elaborate about the neoadjuvant, the immunotherapy or the immune checkpoint inhibitor to downsize the tumor to make it amenable for radical or partial nephrectomy in
Sure. So if we want to do it, you know, I can quickly present case number 9 because that's what it really was on that. Should I do that? Or?
Yes, please. Yes, please, sir.
So in metastatic renal cancer, so this is a patient who had a large right-sided renal tumor. There is even a tumor involving the left kidney, and this is the same patient with multiple pulmonary nodules.
Professor Chaudhary, sir, your sound is not that much clear. Can you bring your microphone? Or
Okay, can you hear me now?
Yes, please.
Okay, so let me go back a little bit. Okay. Okay, so this is the patient. So one of the things we always look for in patients who present with metastatic renal cancer, or a locally advanced renal cancer, what is the performance status of the patient? And it is especially important for the residents to know what is the performance status. Karnofsky performance status 100 means normal, no complaints, no evidence of disease, they feel fine. Asymptomatic patient, that's 100. 80 will be that normal activity with effort. The patient can carry on the normal activities of life with some effort. There is some sign or symptoms of disease. They may have some pain, some discomfort, but that essentially can do everything normal. So most of the time, you want to treat a patient who has Karnofsky performance status is over 80. But again, you know, a lot of these patients might be fit. Let's say a patient with 70, the patient can care for self, unable to carry on normal activity or do the active work. So it goes down, but you most of the time you really want the patient with a Karnofsky performance status of over 80 period. Now, one of the way to look at when you find patients with metastatic renal cell cancer, we got to use some sort of a guideline that which risk category the patient falls. And we use 5 things. One, is the performance status over 80? That will be important. Is the LDH level elevated? If the LDH level is over 1.5, that's the risk factor. Is the hemoglobin lower than the normal level? That's the risk factor. Is the calcium level over 10? That's the risk factor. Absence of prior nephrectomy. If the patient did not have a nephrectomy before, that will be considered one of the risk factors. So these are the 5 risk factors. Again, let's take a look. The performance status under 80, that's the risk factor. LDH is over 1.5 times normal, that's the risk factor. Hemoglobin under normal limit is a risk factor. Calcium level above 10 is a risk factor. Absence of prior nephrectomy is a risk factor. Each of them gets 1 point. If a patient has none of these risk factors, then they are good risk category. If the patient has between 1 and 2 of this risk category, they're intermediate risk. If the patient has between 3 and 5, if somebody has all 5 of this risk category, they are poor risk patient. That's the way we can risk categorize metastatic renal cancer. There are other risk category group. I think this is an easier one to use in this one. And this is the way they do. If the risk category is multiple, 3, 4, or 5, this patient do extremely poorly. If there is only no risk category, this patient do much better in their. So what are the things we can use for metastatic renal cell cancer? We can use the vascular endothelial growth factor inhibitors, which are basically sunitinib, sorafenib, pazopanib, axitinib, cabozantinib. So there are a number of them in the VEGF line. There are mTOR inhibitors, temsirolimus or everolimus, and you have the checkpoint inhibitor, which is the most current one, nivolumab and ipilimumab. So what should be the first line treatment for intermediate and poor risk advanced renal cell cancer? So if you have a poor risk patient, again, good risk patient, sunitinib, sorafenib still is good option. But if it's a poor risk patient, what is the best option really? So this was a trial. It's a randomized phase 3 trial looking at 1,096 patients with intermediate to poor risk features. And what they did, they used nivolumab plus ipilimumab versus sunitinib. So in one group of patients, there are 2 drugs, checkpoint inhibitor, nivolumab, ipilimumab, and another group of patients had sunitinib in advanced renal cell cancer. And this is what happens. Intermediate or poor risk, remember, it was called the Renal Cell Cancer Checkmate 214 study. The complete response rate with the combination of checkpoint inhibitor, complete response was 9.4% of 425 patients. With sunitinib, it was only 1.2%. The partial response with the checkpoint inhibitors was 32% versus 25% for sunitinib. Overall response was 41% versus 26.5%. So it appears the patient with advanced renal cell cancer, especially with poor to intermediate risk feature, do better with the combination therapy than sunitinib. But again, sunitinib may be perfectly fine for the low risk group of patients. And again, when you look at the same study, if you look at this, is the top line is the combination and the bottom line is for the sunitinib. That means at 18 months follow-up, the patient with combination of checkpoint inhibitor does better than the VEGF inhibitor for intermediate and poor risk patients. So overall survival and objective response rate were significantly higher with the combination of these two drugs than with sunitinib among intermediate or poor risk patients with previously untreated metastatic renal cell cancer. And I believe this is the last slide. Okay.
All right. Anybody, any oncologist, Professor Mozal Hossain, Dr. Kamal is present here. Do you have any experience in this country about immune checkpoint inhibitors in renal cell carcinoma?
Mr. Mufaddal, yes, we have been using it for a long time. Nivolumab in particular, I have used in many renal cell carcinoma patients, as well as in hepatocellular carcinoma. And ipilimumab, actually, this used to be a standard treatment for melanoma, malignant melanoma metastatic. And now in combination, this ipilimumab and nivolumab, as has been shown right now, is the first line choice of treatment for metastatic renal cell carcinoma. But unfortunately, ipilimumab is not, neither ipilimumab nor nivolumab is available in our country. We have to get it from outsourcing. So we do not know when it will be available. But these have a very good side effect profile. They are very well tolerated by the patients. The one important point is that they can produce some pulmonary fibrosis, pulmonary lesions, which in the era of COVID disease, COVID-19, they may be an additional problem. So we have to be very careful and monitor the patient very closely for this when we start treatment with this ipilimumab and the nivolumab. That's all. Nivolumab is very good drug. It's well tolerated, safe drug, and it's effective as well. It has other indications, but renal cell carcinoma and hepatocellular carcinoma, they are getting more important.
What about the toxicity? Are they toxic or less toxic?
They are very less toxic.
Right. Any comment from Dr. Kamal? Or?
Yes, sir. What about the pembrolizumab?
For this pembrolizumab and axitinib is the recent recommendation giving a better outcome. But yes, I agree with Dr. Fajal that the toxicity profile is safer, but the financial toxicity is so high that is a big concern, because we need to continue this drug until disease progression, and the availability and the cost is a very, very big challenge. Yes, it is very promising, and now the recent recommendation is the highest survival shown by pembrolizumab and axitinib combination. But every single immunotherapy, the challenge is unavailability and the cost. So we don't have very frequent experience, limited experience. Experience is good. And,
can you tell the audience how much about the cost?
Is very high.
Axitinib and pembrolizumab combined cost, how much?
I have not used this combination. Pembro for liver RCC I have not used. Dr. Mufaddal, have you used pembrolizumab and axitinib for RCC?
Not pembrolizumab, axitinib, no. Axitinib I have used, pembrolizumab used separately, but combination I have not used. Ipilimumab and nivolumab I have used in this combination in melanoma. The cost is about 4 lakhs for every 2 weeks treatment. And nivolumab alone,
continue.
Right. It has to be continued for indefinite period, as long as the patient can tolerate as well as get result, positive result. So it's once it is available and manufactured, probably they can be within of the future.
May I openly ask any comment or questions from the audience? We're going to finish the things now. And
but there was a question from Professor Salam about neoadjuvant immunotherapy. There is a study that you can use neoadjuvant immunotherapy and go for surgery. And even during immunotherapy period, surgery is safe. There is a safety profile study, and that is a recommendation that can be practiced just for the comment.
thank you.
Okay, thank you.
So if there is no question or comment, anybody, any final call? If any questions or comment? Right. Can I ask Professor Salam to, as a chairperson, make some comments before we finishing the session?
It was an extraordinary meeting. For the last 2 hours, we have been discussing the most difficult and challenging cases of renal cell cancer, and which is a killing disease. And as the time is going, we are surprised to see that the renal cell cancer is becoming a problem as an incidental mass, as well as on routine examination. We are discovering more and more RCC in our clinical practice. So it is important to learn everything. We have organized this meeting in the form of masterclass. We have completed very successfully with 4 parts. So Professor Chaudhary has contributed huge task, and huge amount of information actually has been displayed. And I personally learned a lot. I'm sure that the participants who are contributing, they also have learned. And by contributing into the meeting, everyone became benefited. So from the viewpoint of the organization, we are so grateful with the faculty, the moderator, the participants, and finally the panelists. And because of their contribution, this meeting became so nice. With this P word, I would like to conclude here. And we are looking for the next meeting may happen in 2 weeks' time. Maybe we will be discussing the prostate cancer in the form of masterclass. Maybe since this is a prostate cancer is a big subject, big issues, so it may also be divided into 3, 4, 5 parts. So initially we may go into the primary knowledge of the basic work, like evaluation of prostate cancer, and then the other areas will be discussed. So I hope you will participate with your friends, colleagues, residents, and the friends here as well as abroad. I would like to request Professor Chaudhary, Professor Mother, and all my friends to collaborate so that the meeting becomes very good for the benefit of the others. Having said that, I would like to stop here. And if there is any point,
So thank you, everybody.
Tangi would like to
stay safe.
Thank you, sir. Thank you for your effort. You always welcome.
Thank you.
Thanks, everybody.
So we may conclude here. Hopefully, we all will be fine. In the COVID area, in the COVID time, we'll be able to overcome all the calamities. We are looking for the good days ahead.
Stay home, stay safe.
Stay strong also. Thank you very much. So the meeting is postponed here. I would like to thank the organizer of the meeting and the partner of the meeting, UniMed and UniHealth. They have contributed a reasonable help and very effective help by organizing these webinar sessions. And I am very grateful to them. Thank you, sir.
Thank you again.
Thank you.
Sir, assalamu alaikum. Thank you, sir. Allah Hafiz.